Well, let's turn to the 800-pound gorilla in the room, which is the inappropriate use of antibiotics, whether out in the real world or in the hospital setting. And I can tell you from personal experience that docs are pushing antibiotics as if they're tap water. I hate to say it, I love my colleagues, but this is nuts. How do you do
So I think that's another systematic problem, that it's easier to write a prescription than it is to take time to explain to a patient why they don't need an antibiotic. So you get the patient in and out quickly and you move on to your next patient. It's a huge problem. I think we should treat it like the opioid epidemic, that we need to treat it as a public health threat and do better education.
You know, I don't mean to denigrate the primary care physicians, as I don't understand how anybody can do that job. I couldn't do it. Everybody comes in your office and you've got to make real decisions, real time as to what to do. And you've got to make sure that your patients come back and see you. And sometimes patients really want antibiotics. But at the same time, if you're promoting the overgrowth of resistant bacteria and promoting the growth of C. diff in the community and in the hospital, that's got to be taken into consideration. I don't know how you incentivize
Well,
that.
I think there's more and more research showing that as a clinician, particularly a primary care provider, if you spend time with your patient and tell them about the option of antibiotics and the harms, not just the potential benefits, patients understand that when antibiotics are not going to benefit them, they should not be prescribed.
All right, but I'm going to stop you right there because you used the word time.
Right.
The average primary care, I'm told, out there in the real world has about 7 minutes. And if you're going to take the time to discuss the granular structure of antibiotics in that setting, there goes your 7 minutes. And you got nothing left.
Well, I think changing antibiotic prescription habits, is a big topic. We could do an entire session. Maybe next week we can get together.
I'm in. Let's go.
Yeah, I'll be happy to come by. But I think that when you talk about antibiotics within the context of C. diff, I think it's important for clinicians to understand that antibiotics drive C. diff. And without antibiotics, we probably would see far less, if at all. And sometimes you have to use antibiotics because antibiotics, like any other tool, they're like a hammer. You can build with them, you can destroy with them, and they're in your hand. And you have to ask yourself, is the patient going to be benefiting or not? I think at the end of the day, most antibiotic use is inappropriate, and most antibiotic courses are too long. So clinicians have to ask themselves, does the patient absolutely need antibiotics? Can the patient call me back in 2 or 3 days because I think this is a virus and this will go away? And when you use antibiotics, you have to use them for the minimal amount of time and use them adequately. I think at the end of the day, in institutions, and at the end of the day, maybe in networks of primary care physicians, it's going to be all about antibiotic stewardship, because part of that will come from the clinician, and part of that will be a pathway that will be put for the clinicians, the clinician will have to follow.
I can't get away from the Clint Eastwood quote that you reminded me of. You have to ask yourself a question. Do I feel lucky today? Or don't I?
And I actually empower my patients. So when I see a patient with C. diff, I tell them that one of the biggest risk factors for recurrence is more antibiotic exposure. So if any doctor or provider wants to give you an antibiotic, make sure you tell them, I just got over C. diff, do I really need this antibiotic?
Okay, does that work?
I don't know.
And I must tell you that
I don't think it hurts.
I can tell you it does in patients I've encountered who have had multiple episodes of C. diff. They are deadly afraid of getting
I've seen
another
that,
antibiotic.
even in the ICU.
And they should be.
Yeah.
It's really devastating. But I think the antimicrobial stewardship movement, which actually didn't even exist in the mid-90s, we coined the term in the early 90s or mid-90s, has really taken off. And we really are seeing now much more thoughtfulness, at least in the institutional setting, about the use of antimicrobials. And that is, as we try to prevent disease, as Yoav said, there's 2 ways to do it. Keep the C. diff bug away from the patient, which we do with barrier precautions. And the other is don't make the patient susceptible by not giving them unnecessary antibiotics. So you have a twofold method to try to control this disease.
I think the best we can say at this point is it's a work in progress.